Good evening. It's a pleasure to welcome you to today's ESDS webinar on mediastinal surgery. The idea and the focus of today's webinars is a technical session, so to focus on technical details and aspects of surgery. And it's a great pleasure to have an excellent faculty today of very renowned and well-versed speakers in the topic of mediastinal surgery. It's a pleasure to welcome Jean-Marc Baste from Rouen. He's heading the Department of Thoracic Surgery there, and he's also the head of the ESDS Robotic Working Group. And in the first presentation, he will give us an overview on the robotic approach for mediastinal surgery. Then we have Enrico Ruffini from Turin, who is heading the department there, and he was the previous head of the ESDF Thymic Working Group, and he will talk about the topic of extended thymectomy. And finally, we have Bernhard Moser from the Medical University in Vienna, the current head of the ESDS Thymic Working Group, and he invested a tremendous work in the new ESDS Thymic database, and he will present that with a focus on surgical details. So, as always, if you have any questions, please write them in the chat or in the Q&A tool, and we will have the discussion at the end of the presentations. So, Jean-Marc, the stage is yours on the topic of robotic approach for mediastinal surgery, and you can share your screen.
Okay. Do you see my slide?
Not yet. It should be the
Wait a second.
green button on the lower end of.
I'm going to redo it. Sorry. I have to close all my application. Okay. 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 Is it correct for you?
Yes, you just have to switch to presentation mode,
Yeah.
and it should be perfect.
Correct for you?
We can see the presenter version with the next
Wait a
slide.
second. So, okay. Why is like that?
So if you have two screens, it's usually
I've got two
good.
screens,
You
so
have to switch the screens.
and is it better like that?
Yes, now it's perfect.
It's good? It's good for
Yes,
you?
yes,
Okay. So I've got 15 minutes, that's right?
yes.
Okay. So good evening. Thank you, Clemens, for your introduction, and I'm very pleased and honored to present. It's interesting, but it's quite complex in 15 minutes to have an overview of robotic mediastinal lesion, because you will see that it's a very wide subject. So we could start to say, is it a standard in 2026? And we try to go further now. So this is my disclosure. The question in 2026 is which procedure can be performed by rats, which approaches, which robots, and clearly the robot transforms death and narrow spaces into a safe working field. So we are going to start by history and evidences, the feasibility, the safety, the comparison between the VATS and open, early and long-term results, approaches, platform, And you will see that thymectomy is a flagship operation that made robotic mediastinal surgery reproducible, with more than 70% of the description of mediastinal surgery for thymectomy. So the first publication was done in 2000 and not in 2020, sorry. It was 25 years ago by a Japanese team, and it was for a small thymoma. I remember at this time, robotic surgery for carcinoma or for tumor was not very well accepted. The second publication from the same team is for a schwannoma, neurogenic tumor, you see on the posterior part, you can see here. And it was described in 2001 and in lateral decubitus with 3 arms. So now we have a lot of experience. If you look at the first series, because you have 2 series, one from Pisa, from Frank Amelsi, another from Innsbruck. And Innsbruck has done a lot of publication because they have started very early. And in this series, what is interesting is because it was 20 years ago, at this time it was quite safe with 8%, and it was accurate for deep lesion in complex anatomy. And if you look at this time, the thymectomy was 70% of the mediastinal resection. And if you look at all the publication, it's always around 70%, 80% of thymectomy. And the conclusion was the mediastinum should remain an area of special interest for robotic surgeons. It was more than 20 years ago. And they very well describe the position of the robot and the position of the patient, and I think you should keep that in mind because it's still aware 20 years after. For anterior mediastinal lesion, supine position with exposure of the lateral part of the thorax, and the trocar positioning depends on the size, shape of the thorax. But here, what is interesting is the concept of targeting. It means you know where is your target and you position your trocar thanks to. And for medium and posterior mediastinal lesion, the lateral decubitus is used. And at this time, they have published only 3 arms. There is a recent publication which summarize the robotic tumor, the position of the port placement. And you can see in this table, they will exactly describe the same. There is only the dumbbell tumor. They propose a prone position with lateral approach, so you can do the non-surgical and the thoracic part in the same time. So now if you look at the evidences for thymectomy, and so you will see that we are going to compare mediastinal resection to thymectomy. So I will try to be precise on that. For thymectomy, the comparison between open and robotic surgery is in favor of robotic surgery for short-term outcomes in this publication, but with no clear recommendation. In this publication, again, it's a comparison for thymectomy between VATS and RATS in the systematic and meta-analysis. And this publication for short-term outcomes, it's in favor of RATS for drainage, conversion. So there is the same rate of recurrence. And again, it's a very low level of evidences with a lot of indication. In the other meta-analysis, so in this case, it's for mediastinal tumor. So it's a blending meta-analysis. And it's in favor of RATS for conversion rate, blood loss, drainage, postoperative complication, and length of stay. And in 70% is for thymectomy. In this publication, now we look at the long term. It's for thymic, for thymoma. And it's comparing RATS and VATS. So in this publication, there is only less R1 in favor of RATS. There is no long-term difference between VATS and RATS. Another publication comparing thymectomy, VATS and RATS for thymoma. And for long term, there is no difference between RATS and VATS. And this is the publication. I think Enrico probably will describe more precisely. The highlights for thymic malignancy. VATS and RATS are considered the standard of care now for early stage thymic tumors and with lymphadenectomy. In this recent publication for thymoma, they compare open versus minimal invasive. So you will see that they compare VATS and RATS versus open, and there is no difference in terms of 5-year survival. But what is interesting to see, it's a multicentric with patients from 2010 2014. This is the beginning of RATS and VATS. So the proficiency of the team was probably quite low and was at the beginning of the learning curve. But there is no difference between, in short term or intermediate, between open and minimal invasive surgery. And so the conclusion is probably minimal invasive should be preferred. Another publication from one of the biggest teams in the world, from Berlin, from Ruckert and his team. He looked at for large thymoma, not for early thymoma, for large resectable thymoma. So he compared thymoma less than 5 centimeters than more than 5 centimeters. And there is no difference. And this is for rats. So for extended thymectomy. And also he has a look for more than 8 centimeters, group 8. And again, there is no difference. So for the conclusion of this article, which is a very interesting article to read, very complete, very comprehensive, is you can perform robotic thymectomy for large thymoma, but in an experienced dedicated team over 5 centimeters. I would like to say there is very few publication on learning curve, and you know, sometimes this intuitive company advocate to start with mediastinal resection. I would say to be careful on that. If you want to start by mediastinal, please take a patient with large thorax and with small lesion. Don't start by extended thymectomy, for example, for myasthenia gravis, which is more difficult if you need to extend to the pericardial fat. And I would advise for small lesion. So different approach has also been described. So this is a biportal, quite interesting, with a multi-port platform like XI or X platform. Only one publication on that. Another interesting is a multi-port with a single site, like uniportal VATS. It's safe, feasible, but only one publication. I think this is more interesting and to be focused on SP system. If you have access to the SP system, you should consider to do mediastinal resection. So this is the first publication with the first SP platform without capnothorax. Very interesting. In this case, he was in lateral decubitus. You can see that he's superior and lateral. So you can do both supine position or lateral decubitus. I think lateral decubitus is better because you have more space to dissect. Interesting case. Here there is another publication using the new SP with a capnothorax, and this is for all robotic procedures. And here it's the approach from succiphoid for mediastinal resection and subcostal for mediastinal and lung resection. This is the same team from Korea, and you can see here they describe now for mediastinal mass resection, and they use the SP with the capnothorax, and they use the succiphoid approach for thymectomy and the subcostal for medium and posterior resection. And you can see here the publication of this 14 first patient. Very interesting paper. Another paper from the same teams. Now for thymectomy, they precise the indication. They have more experience. And you can see here, you have team from Korea, China, and Taiwan, I think, and also US. This is the early experience, sorry. And probably the future, but you need to get access to this platform. And I think it will be difficult for institutions to have both X, XI, and SP. So to compare SP platform versus X or XI platform, it will be very difficult to see which platform will be better. We will see. And I will also point that the anatomy in Western country with higher BMI could be a problem. What's happened with other platforms? There is publication with CMR, but very, very few cases. And I think it's just for culture. What is your local experience? We use exactly the same principle. We adapt the trocar positioning to the shape of the thorax. You see, it depends the shape, it depends the target, if it's a small thymoma, big thymoma. And you can see here, this is in orange. This is our experience, and this is the French experience from the EPITOR database. And you see that in 50%, we use the left approach and the right approach. So it depends the position of the tumor, but we don't use the subscriptive fluid we have already used, but we have very standardized the left approach, especially for mediastinal myasthenia gravis. And we have standardized and we do exactly like in Berlin, they perform. But we can adapt. And the specificity of my center, we always use an assistant port, and I will advise to have an assistant port for safety. Sometimes we use lateral decubitus for thymectomy. When you have a huge tumor or small thorax or BMI, sometimes it's very difficult to do it in supine position. And you can find a solution with a lateral decubitus. Here, what is interesting, it's a posterior tumor. And you can see here, thanks to the robotic platform, you can do in one stage because you can dissect in the foramen. If you want to go further, I've got many videos for complex and large tumors. You can see here in web search, you can find this lesion here. It's a thymoma. Here, it's another thymoma. You can see here, it's more complex and intrapericardial, left side, but supine position. Here, again. And here, it's an example of two different strategies for large ectopic thyroid and large thymoma. In this case, you use a supine and left approach. And the other case, more than 10 centimeters, I will advise to do right lateral decubitus on the left approach. So to conclude, robotic surgery can now be considered a first-line approach for mediastinal lesion resection. The learning curve remains challenging because heterogeneous lesion, variable anatomy, thoracic shape, BMI, and we need to focus on emerging approaches with the subxiphoid, subcostal, and the new platform. It's highly appealing, but it's difficult to evaluate, especially in Western countries. I will advise also to have a very good pre-op planning, especially for complex. And the problem is the limited standardization due to different approaches, different kind of tumor. And that's why you have a lot of publication on thymectomy. And for large tumor, I think RATS is a very good approach, but you need to have good experience and you need to require a dedicated and high volume team. And I would like to thank you for your attention.
Thank you, Jean-Marc, for this overview on the robotic approach, and we will directly move on with Enrico's presentation on extended thymectomies.
Okay. Can you hear me?
Yes.
Okay. Thank you. Thank you, Clemens. Thank you, the organizers. And it's really a privilege for me to be here to this webinar. So the topic of my presentation is extended thymectomy. Extended thymectomy is not a technique, it's more a concept, you know. So this is why I decided to let me go on. Whoa. Sorry. I cannot move forward. I don't know why. Just 1 minute. Okay. I don't know why I cannot move forward. Okay. Can you see the screen?
No, not now.
Okay, so I have to again okay, just 1 minute. So this is can you see the screen?
No, not yet.
Okay. Oh, okay. So let's start again. Okay. Again.
Now we can see the screen.
Okay. The screen. Okay. You still see the screen?
Yes.
Okay.
Now it's in presentation, but yeah, it's
I think now it works. Okay, so again, extended thymectomy is more a concept than a technique. So I decided to structure the presentation in this way. So first, the definition of extended thymectomy in general, and then just let's see a reply to these questions: when, why, and how we have to use extended thymectomy. And we will finish with a few take-home messages. So let's start with the definition. We have three kinds of thymectomies in terms of the extent of thymectomy. The simple thymectomy, which means the removal of the thymus gland, just intracapsular. Okay, that's it. Extended thymectomy is the removal of the thymus plus the surrounding mediastinal fat. And you can get this transcervically, transternally, or transpleurally. And finally, you have the maximal thymectomy. Maximal thymectomy means something more, the removal of the thymus plus all the fat tissue in the neck and in the mediastinum as much as possible, okay? So in order to put some order in the different thymectomies, the MGFA, the Myasthenia Gravis Foundation of America, decided to classify the thymectomies based on the approach and based on the extent. So T1, T2, T3, T4, and T5, that means transcervical, transpleural, videoscopic, transternal, and then transcervical plus transternal, and infrasternal, that is subxiphoid. Each category is further subdivided into basic, that means simple thymectomy, or extended. Okay, so this is the definition. This is the nomenclature of thymectomies. So the second question is when? When do we apply thymectomy in general or extended thymectomy? So the surgery of the thymus for the surgeon means thymectomy for non-thymomatous patients, that means myasthenia gravis, or thymectomy plus thymoma resection in case of thymic tumors. So I think that extended thymectomy is more a concept that will apply to non-thymomatous patients. And this is why my presentation will focus on that. Okay, so let's start. When do we apply a thymectomy? Okay, we apply thymectomy in the myasthenia gravis patients. We know that there are several subgroups, clinical subgroups of patients, and there is a general agreement to divide myasthenia gravis patients into patients with early onset, late onset. These are usually patients with the acetylcholine receptor positive and either older, more than 50, or from 18 to 50. And then we have the ocular myasthenia gravis. That means myasthenia gravis in class 1, according to the MGFA. And then we have, of course, the myasthenia patients with thymoma, or myasthenia patients with other antibodies like LRP4, MOSC, that means the muscle-specific kinase, and that's it. If you it is important to notice that we haven't had any class 1 evidence for the efficacy of thymectomy until 2016. These are the practice guidelines in 2015 by the American Association of Neurology. And you see here that it was stated that the benefit of thymectomy was not established. And thymectomy was recommended just as a treatment option, and the authors concluded that a controlled trial was needed. And the controlled trials came, and it was the MG trial, randomized patients into medical therapy or thymectomy by extended transsternal open access. And there was a striking difference between the thymectomy patients and the patients treated with medical, with the standard of care in medical treatment at 3 years. Another post-hoc analysis with a 2-year extension evidenced that there was a sustained efficacy of thymectomy over medical therapy alone at 5 years. Okay, I think that this led the American Association of Neurology to update the practice guidelines in 2021, including thymectomy as a first option in a selected patients, early onset, acetylcholine receptors positive, generalized myasthenia gravis. And so when do we apply thymectomy? These are the recommendations, the guidelines that are the most updated ones. So thymectomy is indicated in early onset or late onset, acetylcholine receptors positive, generalized myasthenia gravis as a first choice. Even in acetylcholine receptor negative, but LRP4 positive, generalized myasthenia gravis, thymectomy is indicated. Thymectomy is also indicated in juvenile, less than 18 years, generalized myasthenia gravis, acetylcholine receptor positive. It is not indicated in ocular MG, with exception on a very individual basis, for example, in case of a huge thymic hyperplasia, and it is not indicated in MuSK antibody positive myasthenia gravis. Remember to check for thymoma using a CT scan with the medium contrast in all MG patients. Okay, the next question is why? Why do we use extended thymectomy and not simple thymectomy? The answer is this, because we know that there might be an ectopic thymic tissue in more than half of the patients with myasthenia gravis, located everywhere in the mediastinal fat, So the concept is that simple thymectomy is not enough. Extended thymectomy is indicated. This is a very interesting manuscript that was written by our Polish friends. They did an autopsy study using 50 cadavers, and they found that ectopic thymic tissue was found in 64% of the patients. And they divided the ectopic thymic tissue into areas accessible by standard surgery and not accessible to standard surgery. It is questionable now because we can access almost every space, every area in the mediastinum using robotic surgery, using even VATS, and that's it. But the main message of the paper was that an ectopic thymic tissue is not infrequent in these patients. And also in this manuscript from the Rome group, they found that the presence of ectopic thymus is associated with a worse prognosis in terms of neurological outcomes versus patients with no ectopic thymus. Okay, so extended, because extended means that we have to remove all the possible foci of ectopic thymic tissue. Okay, the next question is how? How do we perform extended thymectomy? We can go through the thymus transcervically, transpleural, transsternal, or infrasternal according to the MGFA classification. So we can access the thymus, the thymic area from above, from below, from lateral, or even in the front. We can do whatever we want. the main message is that you have to do that in an extended way, not in a simple way. According to the different approach, you can see here in the left column, the cervical, subxiphoid, thoracoscopic, or robotic, the feasibility to perform an extended thymectomy means to remove as much as mediastinal fat as possible, is limited to moderate using the cervical approach, moderate using a unilateral VATS, but it is very good, excellent, or even outstanding using the robotic unilateral approach, or even the subxiphoid approach, that where you can have a view from below bilaterally. But of course, the surgeon should be absolutely proficient to use any access, open or minimally invasive, because the approach to the thymus area can be completely different in different clinical settings, ranging from invasive thymomas, advanced thymomas, or non-thymomatous myasthenia gravis. So the surgeon should be proficient in using either open or minimally invasive techniques. So these are the expected surgical specimens that we are expecting when we do an extended thymectomy. So apart from this exceptional amount of thymic tissue, this is courtesy of my friend Josh Sonnet from NYU. But these are the usual specimens that we retrieve in case of non-thymomatous myasthenia gravis. You can do that in a very efficient way using robotic. Mark showed the experience from Jens Ruckert, who is a master in robotic thymectomy in thymomas. And this is the same experience in late onset myasthenia gravis. So you can see that they use robotic extended thymectomy as a feasible treatment in patients with a late onset myasthenia gravis, including those with a very late onset, so more than 65 years. I think this is a really impressive series. We are starting with the use of a single port robotic system via infrasternal subxiphoid, and we are very, very satisfied in this. We are just starting, so I took these pictures as a courtesy from René Pedersen. René Pedersen, a great friend of mine, he is starting his experience using a subxiphoid single port robotic system. You can see the excellent view from below and bilaterally. And this is the specimens that he retrieved. So I think this is extremely attractive for non-thymomatous extended thymectomy. But what the difference between the different techniques? This is the first manuscript that was written by Marcin Zielinski 15 years ago, comparing the basic thymectomy versus extended thymectomy. And you see here the striking difference in the complete remission rate between the basic thymectomies and the extended thymectomy. So no way that extended thymectomy should be used in non-thymomatous patients. I just collected two meta-analyses, investigating the different surgical approach to thymectomy, basic versus extended. And again, there's no way that the basic thymectomies has a lower complete stable remission as compared to all extended thymectomy. You can do extended thymectomy by open approach or even minimally invasive approach. Open approach and minimally invasive approach has the same rates of complete stable remission, but minimally invasive approach have a lower morbidity in terms of blood loss and length of stay. And this is exactly the same. This is another meta-analysis published a couple of years ago. Again, there is no difference in complete stable remission between open and minimally invasive techniques. That means that minimally invasive techniques are not inferior to open approaches that has been considered the standard of care until very recently. But at the same time, minimally invasive techniques, either by VATS, RAS, uniportal RAS, or whatever you want, is associated with the less blood loss and length of stay. So let me conclude with a few take-home messages. So the definition, extended thymectomy includes any technique which removes the thymus gland plus the adjacent mediastinal fat using either minimally invasive or open approach. The nomenclature that should be used is the MGFA thymectomy classification. Thymectomy is indicated as a first option now, recognized standard of care in early onset generalized myasthenia, late onset generalized myasthenia, acetylcholine receptors positive, and in selected cases of LRP4 positive generalized myasthenia. Extended thymectomy is always preferable to simple thymectomy because of the frequent occurrence of ectopic thymic tissue in the mediastinal fat, which are associated with the lower response rates and the MG persistence. And so extended thymectomy, whatever access you want, should be considered the standard of care among the thymectomy techniques. And finally, there are no differences in neurological outcomes using open approaches and minimally invasive techniques. That means that minimally invasive techniques are as effective as the open approaches. You can use whatever techniques you are more proficient or more confident with for extended thymectomy. And they are associated with a lower morbidity, lower length of stay. And so, in my opinion, and I think that as a general opinion, minimally invasive extended thymectomy should be considered the standard of care in experienced centers for non-thymomatous myasthenia gravis. Thank you very much.
Thank you, Enrico, for this nice overview. So we will directly move on with Bernhard's presentation on the new ESTS thymic database and how all these surgical details are captured there.
Okay, Clemens, thank you very much for this kind introduction. And thank you all for the opportunity to talk about the ESTS thymic database and the ESTS thymic working group today. I have no disclosures. It's a pleasure to introduce the ESTS thymic database and the new ESTS thymic database and the working group to you. I will walk you through the reasons behind the development of this new thymic database, our goals for ongoing improvement, and how we aim to make it a valuable resource for the entire ESTS community. Finally, I will give you an overview of our current projects and, of course, explain why we would be delighted for you to join us. So in 2010, the ESTS thymic working group was founded. We have one of the leading figures here. It's Enrico. In 2013, he developed the prospective database, an online tool with pre-operative, intraoperative, post-operative data and follow-up data. These data support publications, presentations. It's free access for all ESTS members. It's an option to propose studies for all participating contributors. It means authorship opportunities, and currently there is more than 4,000 patients from 80 centers around the globe. And it's an international collaboration with ITMIC, ISLAC, national registries, contributions to the TNM classification, and we are in the currently harmonizing our data for future projects with international databases. So this is the ESTS website. Here you can see the current list of members to the ESTS thymic working group. There are 61 members listed as experts in thymic surgery research, and the working group develops and coordinates the thymic database, performs multi-center studies, cooperates with international databases. We wanted to give the thymic working group a new face. We started our social media effort in June. Now we have almost 900 followers, so this is growing quite well. We provide several services such as ESD approval of the individual ethical approval, and the communication, I have to say, through social media is much more efficient and better than the email communication. So why do we collect the data? Here, this is the database report from 2025. You can see 4,000 patients, and the data give us information, for example, on this is a registry, of course. Don't forget, this is the very motivated thymic experts that voluntarily donate their data. And these centers, more than 90% do a total thymectomy compared to less than 10% partial thymectomy. This is done with various surgical approaches. I marked the minimal invasive ones for you. For me, always interesting, almost 90% of the resections are complete resections, and 80% are done without a preoperative biopsy. So all this is information which we can derive from the database and cannot be derived from smaller studies. It gives us quite a good overview of the different histologies. And how did this work? Enrico, back then, wanted to increase the completeness of the data, I guess, and introduced a minimum data set. So this was 16 parameters, and this worked quite well. And of course, this led to many successful publications. So in the previous registry, over the last few years, unfortunately, even with the minimum data set, we had a lot of missing data. I will show you in a second. And this is most likely because we had this grayish type of input method here, and you really wouldn't know what is important and what is not important. So there was missing and incomplete variables. There was inconsistent staging data, poor logical structuring. A lot of the surgical methods were missing. And the completeness of mandatory variables, the 16 variables, was just about 66%. So if you look at this analysis from K-data, you can see, for example, chemotherapy, radiotherapy, the data were just not in the database, but we need this information. So there was on the one hand a problem with completeness of the data, and on the other hand, a problem for the future with data granularity, because we have 16 variables and most of it is well published, we have to say. So we are a surgical database, and we just need more data, what people are doing and about the outcomes. But how can you motivate people to put in more data if there's already a problem with data completeness? So we decided to improve the registry with modern features. So we color coded the fields. We have default answers. So the most likely, the most probable answer is already inserted. The data contributor just has to check it and change it if necessary. We automated T&M staging. So you put in the T, the N, the M, and the computer calculates the rest. We have collected all modern chemotherapies on the market for our patients right now. I will show you some examples, and it's easily selectable. We have most of the surgical approaches that you can type in now, and of course we're up to date with WHO pathology. And how did we improve the database? We used the PDCA cycle, so we talked to the programmers, added the new features, implemented this complete new version, did a pilot with many centers, and surveyed the results and refined the results again. And this is something we want to do periodically now. Improve the database, do testing, get results from the users, and improve. So you see, the new phase is color-coded. The compulsory fields are clear. And you can see there's a lot of answers already. So if you go down to the green ones, for example, need for oral anticoagulation, it says no, because most of your patients will not have anticoagulation. ICU preoperative prevent. No, most of your patients don't need an ICU. But you, as a data contributor, have to go there, just glance over it and say, okay, my patients, no DOACs, no platelet inhibition. This page is fine, go to the next page. But if your patient has DOACs, you just change this field. So this makes the data input much easier. So what about the surgical approach? Here the VATS approach was selected. Let's say you select a robot. The robotic tab opens, which wasn't open before, and then you put in the most relevant robotic information. So, yeah, WHO, we have all the histologies, not just A, B, B1, B2, B3 anymore. We have everything in there. We have so-called mouse overs. So you take your mouse, go over this information icon, and it will give you the definition. One of the problematic fields was which structures were involved by the tumor. Most of your tumors do not involve the brachiocephalic vein, the pulmonary artery, the arch vessels, the ribs, and so on. So it also is not applicable. But if you resected the brachiocephalic vein, well, you just change this one tab and you're done on this page. So there is a good chance we have no missing data in the future. So this was the pilot, 23 centers, 231 cases were entered for the pilot. Just have a look at this light blue curve here. This was the resected structures. The data completeness was somewhere just about 50%, but it went up to almost complete with the new system. Again, the light blue line, this was chemotherapy. The information was just not there in the last 5 years. Now it's there, at least in the pilot phase. We did a survey, asked the data contributors, how did this work for you? At least 85% were very satisfied with this new format. So just want to show you one more thing. Chemotherapy. We asked ourselves, how could surgeons possibly give this chemotherapy information? So we put it all there. It's all with mouse overs and easily selectable, and I hope we get this information for the future. So this is the current projects. We did this call on social media and per email, as we are used to. The first project, Francesco Guerrera, asked for your data to analyze postoperative radiotherapy in the context of TNM9. We have Carol Corazzi, who wants to do a propensity score analysis of minimal invasive surgery versus open surgery. I put this project out already a few years ago, but the data completeness for the propensity score analysis was just not enough, and I hope we can achieve this with this new database. And we have Marco Chiappetta, who will analyze neoadjuvant and adjuvant therapy. So the outlook. This presentation is given in the middle of a transition phase. So the features that I showed you there will not look exactly the same after the transition to REDCap. Today, actually, I was able to log into this new system for the first time, and we are looking forward to work together with the University of Padua to get this to the thymic database we want to have. At the annual meeting, there will be a joint session between ESTS and ITMIC. I hope to see you there. And we will also have to organize a thymic working group meeting. So I want to conclude, thymomas and thymic carcinomas are rare and heterogeneous malignant tumors. RCTs are frequently not there, so we use best available evidence for decision making, and of course, we still have a lot of controversies to solve in this rare disease. So please join us. You can contact me directly. You can contact the investigators that I showed you above directly for the projects. The best is you contribute your data and participate in all projects. And please follow us on LinkedIn or X. We are there for you, and we hope you join us and we can do this research together. Thank you very much.
Yeah, thank you, Bernhard, for this nice overview of the current status of the database and ongoing projects. So, for the audience, please insert your questions into the chat function or the Q&A tool. So, I would like to start with a question for Jean-Marc. I think mediastinal surgery was really one of the first fields where the technical advantage of the robotic platform became evident. Several new technological advances have arrived, ICG, augmented imaging, different platforms became available. Do you think there is any of the new technical features or of the progress made in the robotic field which is particularly relevant for mediastinal surgery or which can lead to a transformation of the surgical procedure or an extension of the indications?
Thank you, Clemens. So you have two domains in the answer. You have for classic indication, for not large tumor, probably alternative robotic platform like SP could be an alternative. The problem is a competition between the platform because we are going to be very few to have access to multi-port platform and also a SP platform. And each time you need to gain experience, if you want to masterize the SP platform. I think it's a super platform, but it takes time. So it's about experience, it's about cases. So I think for standardized, simple procedure, this platform will challenge the multi-port platform, but it will be difficult to prove it, okay? But I'm sure this platform will be expanded. I'm sure about that. For the second domain, for more complex, for larger tumors, I would say that the multi-port platform, we have experience now, we have feedback, we have movies, and so I would say that it will be difficult to be challenged by the new platform like the SP platform. Because I think the field, the operative field is a bit different. So to conclude this answer, I think it will be difficult to compare, in fact. It will be difficult. So my point of view is for safety reasons, you need to gain experience. And for larger tumor, I think the multi-port approach will still be the good approach. But we can discuss about that in 5 years with more experience.
Okay, thank you. So, Enrico, you've talked about extended thymectomy, but more or less staying in the field of the mediastinal fat tissue. Are there any recent advances in thymectomies with extension into neighboring organs? Since it's a rare tumor, the evidence we have on the best treatment approach is still is limited mainly to series, and the ESTS database is actually the largest database, which also contributed towards thymic tumors extending into the pleura or into the adjacent vessels. Are there any recent advances in this field?
Thank you, Clemens. Of course, for the interest of time, I limited my presentation to non-thymomatous, of course, thymectomies. When we talk about extended resections, yes, I think that still the main prognostic factors in thymic tumors, in surgery for thymic tumors, still remains complete resection, microscopic complete resection. And in order to do that, I think that we have to be ready to resect as much as possible. We cannot rely on intraoperative frozen section to assess the completeness of resection. That would be nice, of course, but it is not sensitive. It is not sensible. So at least in our experience, I mean, last year we did several cases of thymomas extending into the vessels, I mean, the venous vessels. And I think that in this case, at least in our experience, a multidisciplinary collaboration is essential. We rely on our friends, the cardiac surgeons, every time we have to go deeper into the pericardium, into the venous vessels, and we are very satisfied of the collaboration on that. Another point of interest is extended resection to the pleura, for example. When the thymoma extends to the pleura, it may stand in the form of pleural implants. And in that case, how extended should be the resection of the pleura? Even if there are few implants, would it be worthwhile to resect the whole pleura or not? And this is another open question. I have no answer on that. We rely on resect only the evident disease. But again, the message is that the more complete the resection, the more extent the resection, the better it is.
Yeah, thank you, Enrico. Bernhard, can you please stop sharing your screen for a moment so we can see each other better? Jens Rückert is asking a question, which is basically for all of the presenters. So what about the schedule or the mode of analyzing ectopic thymic tissue, whether this was present or not? So Bernhard, maybe you can start on that.
Well, I think in routine cases, the ectopic, the resected, the question is the ectopic resected thymic tissue. I think it's macroscopically judged by the pathologist, and we always get a report on the thymus. We get a report if this was a regular thymic tissue, a regular thymic architecture, of if there was thymic hyperplasia, or if there was plasma cell follicles in there that produce the antibodies. But for study purposes, we did a more structured analysis of many sections in this thymus, which is not routinely done in every case, I think. But we know from studies, I think this the point he wants to get to is that ectopic thymic tissue was found even beyond the phrenic nerves, behind the thyroid, quite far from our extended thymectomy field. Enrico showed the maximal thymectomy, which by definition is sternotomy, cervical incision, quite an invasive procedure that we do not offer for routine cases anymore. And I think with the robot we can do what both speakers described here, an extended total thymectomy. But in our case, in myasthenia, we operate from the left side, so it's easy for us to tackle the thymic lobes and the fatty tissue that go beyond the phrenic nerves towards the aortopulmonary window. But obviously not be able to dissect all the fatty tissue behind the thyroid. This approach may also not dissect all the fatty tissue down at the cardiophrenic angles. A subcostal approach may be better for this. I think all the approaches that are out there harvest the thymus a little differently. And this brings in again the maximal thymectomy. But yeah, our patients with myasthenia are young. It's usually young females. And our neurologists, I think all our neurologists like to refer for thymectomy because we have a cosmetic, quite low risk surgery to offer. And I remember when I started, when I was a resident, the referrals went down when sternotomy was still the procedure of choice. And this changed completely with the minimal invasive procedures. Yeah. I think Professor Rickert would probably be one of the best persons to answer the question that he put there.
Well, he was asking the question. His suggestion what to do is 4 definite regions: orthopulmonary window, orthocable groove, left and right cardiophrenic tissue.
He knows the answer. I'm sure he knows the answer. Jens is a very good friend of mine.
Enrico, Jean-Marc, anything to add?
Just a few words. Let's say, if you look at the manuscript from Jarek, from the Polish guys, and you see, of course, ectopic thymic tissue can be seen everywhere, but there are some places where there is more frequent. And the most frequent in the cadaver studies was in the left phrenic nerve, beyond the left phrenic nerve. And the authors at the time said that that was an area not accessible to standard surgery. But now with the robotic surgery, everything has changed. So you can go very well dissecting along the phrenic nerve, and you can resect everything from there. So I think that the robotic approach, this is our experience, but of course, Jean-Marc is much more proficient than us, really made a major improvement in also in the resection of these ectopic foci, ectopic areas. I think this is my impression.
Yeah, we have to be a bit careful if we discuss about myasthenia gravis. Of course, with a robotic platform, when you are very well standardized on the left approach, you can remove the pericardial fat easily on the both sides with the left approach. But I would say that you have to be careful with the phrenic nerves. I mean, it's long nerves, and if you are too aggressive, you can have a palsy, which is not a good option for a myasthenia gravis patient. So I think we need to be careful, especially also for the thymoma, because extended thymectomy is good, but you know, it's a long disease. I mean, you are not going to die in 2 years because you don't remove everything. So it's a balance. You have to be careful. So when you know well the robotic platform, you can extend all the dissection very well everywhere, not under the thyroid gland. It is only, you can go above the cervical path. So you can remove the pulmonary aortic fat, no problem. You can remove all the fat around the heart. But from my experience, we have in my series 2 or 3 phrenic nerve palsy, okay, even with bipolar, even if we are very careful. So I would say it's a balance. I'm going to be careful. The message for me is extend your resection, but be careful with the phrenic nerves. Yeah.
Bernhard, is this a feature that is captured in the new database, or are there any new features from the data granularity point of view in the new database?
Yeah, we capture a large bulk of data now, but we offer features that allow for a data input that doesn't take much longer. And we hope that this will be widespreadly adopted, but the first feedback is good, and people have started to put the data in. Yeah, we are a surgical database, and thymoma is really a tumor for the surgeons. And the ESDS database is the perfect tool. We are far beyond researching complete resection as the biggest prognostic factor. We know that already. Now we have to go into more detail. So we need the detailed data, and we need them from many patients in order to be able to analyze. We want to do proper analysis, propensity score analysis, for example. For a lot of the research questions, of course, yeah, we would love to have randomized controlled trials, but the problem is we have to wait quite long for our patients to die, which is a good thing. And also we have to wait a long time for the recurrences. So RCTs are just not really feasible. I think also the randomized controlled trial for myasthenia gravis is a good example. If you look at it, I think they had 6,000, 8,000 people screened, and the actual trial just had about 100 people that were suitable. So RCTs in our field are hard work. They're possible. But I think the ESDS database for a lot of questions is a very, very good tool. And we should pursue it as much as we can work together and make our decisions in the future easier with data.
Okay, thank you. We've already gone beyond time, so we have to finish for today. So I would like to thank all of you for your excellent presentations and also for the good discussion afterwards on this highly specialized and focused topic today. So I would like also to extend the invitation for the next ESDS webinar, which will take place in exactly 1 month on the 9th of March. And it will be on the topic of oligometastatic, borderline resectable non-small cell lung cancer, and the discussion operation versus radiotherapy. And I hope to see many of you there as well. For today, thank you and enjoy the rest of your evening.